Going live now.
I'm sorry, I didn't get that. This is Betty Ann Nettleton. I'm presiding chair over the Central District Health meeting. It is July 7th at 4:07 p.m. I do apologize for the connection delay. I will call the meeting to order, and I will start roll call with Boise County. If you will state your name, please.
Ryan Sturm, County Commissioner, Boise County.
Okay, thank you, Ryan. Valley County.
Betty Ann, Valley County is not represented today.
Okay, Ada County.
Betty Ann, this is Ted Epperly, physician member present.
Betty Ann, this is Jane Young, present.
Betty Ann, Diana Lacciando, Commissioner, present.
Thank you. Elmore County.
This is Megan Blanksma, appointee, also representative of District 23.
Okay, thank you. Okay, folks, we're going to move on with action items here. First, we have a change to our agenda. It will be a discussion and vote on improving the amended third to include COVID-19 status update from St. Alphonsus and St. Luke's Health Systems.
Madam Chair, I'd like to make a motion to include a presentation from both St. Al's and St. Luke's on their COVID-19 status update. This is Diana Lacciando.
And this is Ted Epperly, and I will second.
Thank you. Hearing the motion, if there is no further discussion, I will move on to a roll call vote for Boise County.
Commissioner Sturm, aye.
Ada County.
Jane Young, aye.
Diana Lacciando, aye.
Ted Epperly, aye.
And Elmore County.
Madam Chairman, I'm a no, and with permission, I'd like to explain my vote.
Oh, okay. Go ahead, Representative Blanksma.
I just want to, again, impress my concerns about last-minute adds to the agenda. I want to make sure that the public is completely involved, and I have deep concerns about that not happening.
Okay, we will, the vote, if that's recorded as a no, correct, Representative Blanksma? I had trouble hearing you.
You're correct. Thank you, Madam Chair.
Okay.
No,
All
you're
right,
correct.
Thank you. Okay, thank you. The motion passes, so the floor is open to discussion.
Well, I'll start. This is Diana Lacciando, and I just really want to extend my appreciation and thanks for both our hospital systems to joining us today. I know they are in often a very frequent consultation with our staff at Central District Health, but I think it's really important for us to hear from them as a board as well. So appreciate you taking some time out of your exceptionally busy days to come and chat with us about what you're seeing and what you're concerned about. So with that, I don't know, Madam Chair, if you would like to have them kick it off or how you want to handle it.
Yes, either St. Al's or St. Luke's. Representative, go ahead.
So good afternoon. This is Odette Bolano from St. Al's. Thank you for inviting us. I will give you a little bit of an update from St. Al's, and if there are any questions to we can definitely answer them. And I have Katie, who is our safety officer and incident command lead, also in the room with me. So over the last 2 weeks, we have been seeing a significant increase in the number of patients in the hospital with COVID. I would say probably 7-8 days ago, we started with 3. We went up quickly to 9. We went to 16. We went to 21. And today we are at 27. We have 6 patients in our ICU. Now only one is vented, and I would just like to denote that I know that many people have been looking at vent utilization, but a lot of the treatment has changed over the last few months as we've learned more about this virus, and high flow oxygen seems to be a better methodology. So while vent utilization is one factor, it's not the most critical factor anymore that we're seeing. The number of ICU patients is lower than what we've seen. We've gotten as high as 11 in our ICU, so we're down slightly. We are seeing some younger members of our community, so in their early 60s, early 40s, in our hospitalized for COVID. We are pretty concerned about the significant numbers and how quickly they are rising. We are also seeing a lot of positive tests coming back, patients that are not needing hospitalization but are sick and are recovering at home. Our whole entire test system is overwhelmed at this point. We just got off a call trying to figure out how we manage the number of people wanting to get tested and the test capacities that I'm sure you all have heard about being overwhelmed and taxed across the country as there's increased testing. Even the commercial labs are overwhelmed at this point of the number of tests. So we are seeing delays in response of results coming back because we do use some outside labs to help the non-inpatient volume to be tested. And so we're starting to see some significant issues there. So, I've heard things or questions about, are we overwhelmed? I think that we are meeting twice a day to really evaluate as we have been ramping up to get people who have had delayed care back into the hospital to get the treatment that they have, and assuring that we've got enough ICU beds still open for any huge influx of COVID patients that would be unexpected. And the reason I ran you through our numbers and how quickly that we're moving is that we've got to be ahead of this issue. We just can't wait. We're not going to get one patient at a time. We're getting 4 or 5 at a time. We are seeing more patients from Ontario and Napa as we're trying to cohort just for an effort of keeping our staff well competent in taking care of these patients. Right now, we have small pockets of PPE concerns, such as gloves and shoe covers. Those aren't really important, the shoe covers. Some isolation gowns, we're using reusable isolation gowns. But we see some stability in the PPE, but as the numbers continue to rise, right, we're all super interdependent on what's going on across the country to get our supplies. We're concerned that there may start being more shortages about PPE. We can't look into that far future. But as we remember, maybe 3-4 months ago, this is part of what started happening, is that we started to overwhelm the system. So I will pause there and see if there are any specific questions that I can answer on behalf of St. Al's.
The floor is open for questions for Odette.
Madam Chair, this is Commissioner Redstone. I got a question.
Yes, Ryan, go ahead.
Are you guys taking into account or counting numbers of patients that are coming from rural areas that don't have a hospital or proper hospital available to them, such as, Washington County or Boise County, Valley County, those hospitals and those medical systems that could not, wouldn't be able to support the level of care that would be needed to provide for patients that are getting sick there. Are you kind of keeping track of those folks coming in, or only in the general metro area?
Thank you for the question. This is Katie Dudley with St. Alphonsus. So we certainly capture the patient home residence as their data metric as, you know, where they're coming from. And I know from our public health standpoint, if there's confirmed cases, you know, in the community, they are looking at where that individual's home residence is reported. So we definitely are tracking more than just Tampa, Boise metro area as far as where the patients are coming from.
Betty Ann, this is Ted Epperly. If I can ask a question as well.
Yes, Dr. Epperly, go ahead.
Thanks, Odette, for the overview. Based on evidence that you might be aware of, Odette, from the hospital communities in other states that have gone through considerable problems with COVID-19 outbreaks, New York, New Jersey, Florida, Texas, Arizona, et cetera, with your increasing numbers from 3 to 9 to 16 to 21 to 27, do you have any forward-looking thoughts in regards to what this might look like 2 to 3 weeks from now?
So thanks, Ted, for the question. We'll go through a couple of things from our predictability models. So there's a couple of things that we watch. You know, we begin to pull our first lever when we see more than 100,000 cases per 100,000 population. I mean, 100 cases per 100,000. And we're over that mark. I think, you know, and believe me, these numbers are changing all the time. I think we were like at, for Ada County, 323. So 100 is our first blush. We're at 323. The next thing is what we call our R naught, and we like to stay below 1 on that. And that number is at 1.30. Now, I will say that what that means to us is that there is a slow growth. About 2 weeks ago, I believe we got to a 2.3 R naught, which was very concerning. And we were no longer in a decay mode, and we were actually in a worsening mode. So those are parameters that we're constantly looking at to see what actually we should be doing. You know, today we're looking at whether or not we start restricting some of our inpatient surgery based on if they are going to need an ICU bed. So it is getting to the point where we are starting to feel some discomfort in the number of cases that we're starting to experience. And if we look at what we are seeing in the testing arena, I think that, you know, we all know that we need more testing, right? And the more tests we do, we're going to have more positive. But I think the last number I looked at, and please, you know, forgive me, because in 48 hours, the numbers totally change. But I think the last number that I saw, Katie, was 16.5 or 15% coming back positive. So, and we have seen in our testing sites many asymptomatic people coming back positive. And it's the younger population. And, you know, one of the concerns is that the young asymptomatic that aren't practicing social distancing, masking, are passing it over to the more vulnerable, their parents, their grandparents, older people that they may interact with. So we are watching that very carefully.
Madam Chair, this is Diana.
Yes, Commissioner Lacion. Yes, go ahead.
Odette, I just want to clarify for the group, but also for the public that's watching. You know, at Central District Health, we are in charge of contact tracing for our region. Certainly have the opportunity to address mitigation strategies, but we don't have that testing responsibility. And I just would appreciate if you could clarify. I know that you have a member, and maybe Luke's can speak to this as well, about where you all are heading as a cohort with that statewide testing task force to try to improve testing locally.
Yeah, I don't mean to throw it, and I can't even see Dr. Sousa, but I think he's on the state task force. I am not, and maybe he can address the state testing task force better than I can.
I'd be happy to add that to my comments. You want me to do that now?
Yes, go ahead.
Yeah, well, Yes, so the state testing task force is going to reconvene beginning on Thursday. Dr. Chris Ball and I have co-chaired that, and we will be in that first reconvening meeting coordinating a bit of a handing of the baton to a new state testing director, a gentleman named Brock Anderson. Our state's testing capacity really has not substantially changed since the testing task force completed its what recommendations back circa the first week of May. It really has not increased substantially. Across the Curve, Idaho, other sites are certainly performing more testing, but those are largely going out to external reference labs, which, as has already been pointed out, are now starting to jam up substantially in terms of their turnaround time. So that you're seeing turnaround times now push out to 4 days, 5 days, 8 days. And a turnaround time that long renders a test useless. My expectation of the testing task force in its reconvening is, first of all, to be more accurate in what is our testing capacity that actually resides within the state of Idaho. Has it grown significantly from the 18,000 per week that it was circa the first week of May? I think it's only grown a little bit. Second, what are the new categories and indications for testing? We need to get a more complete understanding of that. And then third, because we're going to be in a scarcity situation for the foreseeable future, as long as I can see, we need to get clear about those priority tiers and the allocation of testing resource to those tiers. Let me just state it clearly for the group. If asked to prioritize a student returning to school, or an athlete in order to perform an event, or a vulnerable patient about to be admitted to a long-term care facility, I think there is no question who we will need to prioritize in a scarcity situation. None at all. Finally, and I want to emphasize this maybe more in my comments when we talk about what we're seeing here at St. Luke's. You know, this conversation about testing, that's fine, but we need to be talking about prevention, protection, and mitigation. And testing is a little caboose that's sort of an appendage off of that conversation. It supports those things. Using the governor's own analogy about a forest fire with this pandemic, I mean, talking about testing is like talking about all the ways that you're measuring the fire. It's heat, how many trees have burned down, how many structures have been consumed. We have got to start talking about how we're going to douse the fire. And we have real ways that our communities and our public can engage in that. And I'm very interested in that conversation. Finally, that state testing task force, I do hope, as we get a more firm bead on the actual capacity that exists at the Bureau of Laboratories, within healthcare systems, inside reference laboratories, to the degree that we hone down those top tier priorities that we have to deliver on, perhaps we will find some additional capacity. And I believe that additional capacity, whether it's in the St. Luke's Health System, the St. Al's Health System, the Bureau of Laboratories, the VA, Crush the Curve, you name it, that additional capacity has to be allocated centrally in a consistent way, because actually what we're doing right now is consuming resources that we know we're going to run out of. And we're not consuming those resources in a way that's logical and consistent with a scarcity situation and delivering the testing to the people who need it the most.
Thank you. Further comments?
Betty Ann?
Yes,
Madam Chairwoman. Thank you. I would just have a question about the predictive modeling. I'm curious if that's been shared on a regular basis with either Central District Health or the state.
Yes, this is Katie with St. Alphonsus. We have shared our information on a regular basis.
So to be clear, then Russ Duke has had access to the predictive modeling that could be shared with the board?
So I just want to clarify, we're not sharing our predictive modeling, we're sharing our data.
We've shared the R0, as Odette just discussed, we've shared the R0 and what we're seeing, what our experience has been, the data that we have access to. We don't have any data that's saying, 3 weeks from now you're going to have X number of patients. That's not what our predictive modeling looks like.
Okay. Thank you, Madam Chairwoman.
Yes.
Follow up?
Yes, go ahead.
So I was just trying to be clear. I mean, I appreciate that you're sharing data, but I also know there's modeling going on with the hospitals, and I just wondered if that was currently being shared.
I'm not sure that what you're asking, but we have our modeling. Just like I shared the information from our modeling today, I think that Katie and Dr. Nemerson, who's not here today, have been sharing that information with Russ at the other meetings that they've been having. So we don't actually give them our predictive model, but we share the data that it's showing.
Madam Chair, this is Ted Epperle.
Yes, Ted, go ahead.
Thank you. Dr. Souza, thank you for your report and the data. That's very helpful. Jim, were you also going to speak to St. Luke's experience, or was Chris Roth going to do that in terms of what you're seeing internal to your hospital and systems?
Yeah, I think we're going to tag team on that. And Chris was going to tee it up.
Okay, this is Chairman Nettleton again. Would Chris or Dr. Souza like to go ahead with that discussion, please?
Sure, I'd be happy to. This is Chris Roth. I serve as President CEO of St. Luke's. I'm going to offer some observations and then turn it over to Dr. Souza. And I'm going to share a few of our statistics, much like Odette did from a St. Alphonsus perspective. Today, we have 51 COVID-related admissions in the hospital, 14 of whom are in the intensive care unit. As a system, we have 57 ICU hospitalizations across the system. Most of these are non-COVID because we are continuing to treat people who need day in and day out care, although our ICU capacity is running about 130% of normal. I want to put into perspective the 51 admissions that we have today. That compares to an all-time high in the months of April, May, and June of 41. That was the high water mark. And in the last week, we've reached a new high water mark, if you will, just about every day. It also, as a reference point, compares to an all-time low of health system admissions of 2 on June 8th. So we've certainly seen a rapid rise in cases. I would say the last 3 weeks, we're seeing about a 20% increase in COVID-related admissions per week in general. We have 26 individuals on ventilators. Most of these are not COVID. Odette spoke about the changes in treatment, but that's running 200% of normal capacity. I want to talk a little bit about one of the risk points that hasn't come up yet in a significant way. We've talked about PPE and some of the challenges there, and we remain hopeful that the supply chains are sustainable, but the demand of PPE can shift rapidly. And so as the increase in patient volume increases, so does the consumption of PPE. I want to talk about our healthcare workers. Many of you are familiar with what we experienced in Blaine County with massive infections in that community. The mixing that occurred within the community and the transmission of COVID really, frankly, overwhelmed the system. In that case, we ended up essentially closing the Wood River Hospital and transferring all inpatients to Magic Valley. We kept open core emergency services. The reason we had to close that facility was we had well over half of our staff who were potentially exposed and on quarantine. Now, back then, we weren't able to turn around the testing as quickly as we are today, although you heard Dr. Souza speak to the challenges with testing turnaround that seem to be rearing their head again. Today, as a health system, we have 80 employees who are out of work with COVID-like symptoms, half of whom have been confirmed positive. The other were waiting on results. To give you a perspective, that's an 11-fold increase. If we look at over the last 6-week period, the last 3 weeks have been 11 times more than the prior 3 weeks. So we're very, very concerned about the health of the healthcare workers. One other point related to the tracing of that, we have not been able to confirm that any of those transmissions are occurring within the healthcare setting. These are individuals who are picking up the virus in their community settings, and then we do all the screening and testing and so forth along kind of along those lines. We're very concerned with what we're seeing and where things are headed. Our modeling shows week after week increases because there's nothing that we've been able to determine is going to change the trajectory at this point, given the collective behaviors of the community. I'll put it that way. I'm gonna turn it over to Jim here to dive into a little bit more detail on what we're seeing. Dr. Souza is our Chief Medical Officer. He's also a critical care intensivist, so he spends some of his time as well in the ICU and taking care of some of our most critically ill. Jim?
Thanks, Chris. I wanted to focus my comments, I think, on the things that we'd love to see in terms of engaging our community in practices that will actually protect the capacity for delivering healthcare. I don't think a lot of folks have experienced exponential growth the way that we did early on in Blaine County, and that I'm afraid we are again right now. The point about an exponential growth phase is that it can turn on a dime. The rate at which you can find a unit or units overwhelmed is staggering. And we experienced this in Blaine County in miniature in our health system circa the last week of March and the first week of April. And what happened there, I don't think that story has been perhaps well told, but over a period of literally 5 days, you know, as things exploded in Blaine County, which had a population of about 22,000 people, and that facility became, you know, as Chris has pointed out, we ultimately had to close it. And our facility in Twin Falls, therefore, received the fallout from that explosion. Over a period of 5 days, we saw an intensive care unit and a step-down unit completely transformed and overwhelmed. Our anesthesia teams, over a period of 5 days, migrated from the ORs, where we then shut down care, to just outside the doors of the ICU where they camped out to perform intubations on patients. That unit surged to capacity, and I'm well familiar with the usual makeup of that unit. It's a standard general mixed medical surgical ICU. It became a respiratory ICU in 5 days. Every patient was a vented COVID patient with ARDS, and we started shuttling patients west to Boise and to Meridian to offload. And it was absolutely white knuckle for that whole week, because we had no idea at that point whether the governor's stay-at-home order, which he had put in place, thank goodness, the week before we started seeing our surge, we had no idea if it was going to work. And then we hit a plateau, and then it started to drop, and we all know what happened after that. And you know, we hit our nadir about 5 weeks ago with 1 patient across our system, and you just heard the numbers from Chris and how that's been transformed. Well, another interesting factoid out of Blaine County experience is in our predictive modeling, in all the models that got put out there, and these erroneous kind of, you know, single hump things where things shoot up to a peak and then they come back down to a baseline. And it's so tragic that that message got out to the public, like it was going to be sort of a one and done. Like we'd hit this peak and it'll come down and then we'll be done. Key to all of those models was this measure of social mixing that's designated by the modelers as alpha. And that unique experience in Blaine County where we had a contained population of people, we actually knew the population. We knew exactly how many hospitalizations came out of that population. We knew exactly how many ICU hospitalizations came out, how many vented ICU hospitalizations came out. We were actually able to go back and solve in a roundabout way for alpha. And that the alpha is on a log scale, so small changes lead to big outputs. An alpha of 1.0 means that every individual in the population has an equal chance of bumping into every other individual in the population. That would be 1.0. When we solved for alpha in Blaine County, long about the first 2 weeks of March, we came out with a number of 0.99. Now, the people on the call can probably imagine then what that number translates into. And you think about packed Uber vehicles, oversold Airbnbs, crowded indoor bars with people shouting and slightly, you know, having a few too many drinks, and people sitting on one another's laps, and crowded ski hills and gondolas and chairlifts. You can see what a picture of alpha of 0.99 looks like. I don't think we're going to go back to that kind of alpha of 0.99, but what a 0.95 alpha looks like is probably about what shelter in place looked like, and I don't think we're going to go back to that either. So now take that population of 22,000, and this is what has us concerned, and think about the population of Ada and Canyon counties, which I think is around 750,000. And think about an alpha that maybe is 0.97. And then you think about the numbers that we're starting to see, and we're very concerned. We are most definitively preparing our surge plans. We're planning to be able to surge beyond our existing ICU capacity, which Chris said we're already at 130% of what we usually would operate. But I want everybody to know that in and of itself, if we do that, that's going to be a public health crisis on its own, because we'll again be faced with people not having valve surgeries that we've put off for 2 months, people not having necessary screening procedures, the vaccination rates that are plummeting. We also can't allow that to happen. Real briefly, in terms of the kinds of things we're seeing in the hospital with this most recent surge in activity, we're seeing a younger population. So our average age of patient has definitely dropped. We're definitely seeing still the entire spectrum of age. And then in the community, we're also seeing the same thing. Dr. Peterman from Primary Health Medical Group has been very generous in sharing his testing data with us. And it's noteworthy that while 4 weeks ago, almost all of the positives were in the 20 to 30-year-olds, that over the last 2 weeks, there's now been a fourfold rise in the 40 to 59 that's turning positive, and a fivefold rise in those over 60. What that tells me as a pulmonary critical care doctor and a delivery system leader is get ready. We're going to be seeing increasing hospital activity, and that informs our own predictive models. I also want to make clear that nothing actually, there's been some good developments, and I want to point that out, but nothing has really changed in terms of treating the virus or creating immunity yet. I mean, there are incremental improvements in treatment, whether it's remdesivir or steroids or tocilizumab or famotidine or others, incremental changes, but it hasn't substantially changed the disease. And while there's really encouraging news in terms of the speed of bringing vaccine technology to market, I mean, 3 phase 3 trials happening, that's staggering that we've, as a species, gotten there this quickly. I think mitigating that, we have to be honest that we're not certain at all that any of those vaccines are going to work. And in fact, within the last 7 days, there's new data out of China around the immunology with this disorder that suggests that protective antibody levels plummet or return to unmeasurable in a staggeringly fast period of time, like 3 months. So we cannot count on being able to vaccinate our way out of this in the foreseeable future. Hopeful that we will, but can't count on it. So if we're going to talk about what things we can do to my point, to actually put out this fire and engaging our public, first of all, I think the messaging on masking, I wish everybody up front would just say that science is imperfect and is constantly evolving and accumulating evidence to become more perfect in its understanding of a disease. And the rate at which we've begun to understand this disease is also is pretty amazing and pretty staggering. But our understanding about this virus has changed in terms of our understanding of how it's transmitted just over the past few months. I mean, in early March, we were thinking about COVID like flu. We were thinking, like contact and surfaces, that's and space. And increasingly, we're thinking about aerosols and droplets. And I just want to touch on some of the lines of evidence that have moved that conversation scientifically. One line of evidence was an unfortunate experiment that never should have happened. I mean, in mid-May, this hit all of the mainstream media about these 2 incredibly irresponsible individuals who worked at a hair salon in Missouri, who were symptomatic, known positive COVID, and went to work anyway, exposed 150 customers until they were outed. And it created an outrage, like how could this happen? Well, the unintended kind of interesting news that came out of that is that those 2 hairdressers wore masks 100% of the time at work, and there wasn't a single conversion event out of all of those close proximity exposures. So that's one line of evidence. The George Floyd protests that happened across the country, but I point out in particular in Minnesota, which has a pretty robust public health infrastructure, we really have not noted an uptick in disease activity that they can attribute to those. And there's 2 important pieces of information about that. Those protests occurred in outdoor settings, not indoor settings, and many of the protesters were wearing masks. And most of the stuff that I saw on TV, I'd say well over half of the people I saw were wearing masks. the basic science about the prevalence and the persistence of this pathogen in small droplets has been growing as well. The World Health Organization commissioned a meta-analysis that got published in Lancet about 2-3 weeks ago now, that demonstrated that wearing masks, even non-medical grade masks, so even in public settings, decreases transmission of this pathogen significantly. They estimated by more than 70%. And finally, there's an increasing scientific kind of consensus lobbying the World Health Organization to officially change its stance on the primary transmission mode of this virus. So, you know, we hope we can advocate for things that should work, which would include, if you've got a choice to avoid going indoors and congregating with strangers, that's the choice you should make. We should be maintaining physical distancing at whenever possible. We should maintain physical distancing, particularly indoors, and we should be wearing face coverings at all times when in public, particularly indoors. That's it.
Madam Chairwoman, I've got a question.
Yes, who's speaking, please?
It's Representative Blanksma.
Okay, go ahead, Representative Blanksma.
Hey, my question is for Chris Roth, if you don't mind. This is a long way from the Elmore County Community Board, I guess, when I knew you last. But I got a question for you. So I've got the email that Luke sent out on July 2nd. And it said they had 55 ICU beds full, which is actually higher than the number you quoted me as the high. And then it said there was 1,289 days of N95 and 405 days of hand sanitizer. And I guess I really want to understand the numbers, because this is the whole point, is all the work that everyone's doing is try to make sure that you guys aren't overwhelmed. But I feel like we're getting away from hard numbers, or at least as hard as we can make them. So can you give me some clarity there?
Yeah, I'd be happy to, and it's good to talk to you virtually. You know, a couple of points. I don't have that communication right in front of me, but as you know, we're sending out every week to our boards and community boards as transparently as we can what we're seeing relative to hospital activity. That includes general admissions, that includes ICU admissions, and so on and so forth. I mentioned earlier today that you know, we have 57 ICU hospitalizations as of a few hours ago, and our capacity is 89. Our volumes are fluctuating daily, but we're certainly seeing a general increase in our total COVID-related admissions from early July to today. Relative to PPE, this goes to my point around we look at supplies usage on any given day. So take N95s, for example. To the extent that we start to see additional increases, and we are, our N95 capacity or hand sanitizer or masks is going to start dramatically decreasing. Fortunately, and I credit our logistics teams over the past few months. Starting in early January, we got on top of the acquisition of PPE, and we have not let up in sourcing that. We learned very early on that we could not rely on the national stockpile. We could not rely on the state allocation. We had to go out and source those supplies accordingly. And along the way, we've also been fortunate enough to be able to support other local healthcare providers in some of their supply needs as well. So it's a dynamic situation. If you've got any advice relative to the data that we're sharing, and maybe there are areas that are creating more confusion, we can certainly reconsider that. But our commitment has been to try to be as transparent as we can in terms of the data, the volumes that we're seeing, happy to talk with you offline about that specific communication. I just don't have it in front of me.
Thank you, Chris. Madam Chairman, just a follow-up comment.
Yes. Go ahead.
I appreciate that, and I do credit Luke's for being, and of course that's my community hospital, so I credit them with being transparent with that information. We're trying to juggle a lot of things, and I appreciate people's concern about COVID, but we also have other health concerns that are out here right now, and you look at the amount of claims that are coming in that are also public health issues with regard to depression, with regard to suicide, with regard to child abuse. And I think the better the model that we have and the better the information we have from hospitals on what they can and can't handle with regard to surge capacity, or if it's not vents now, whether availability of ICU beds, we need to get to some trigger points that we really understand, knowing that if those trigger points occur, there's other consequences to those decisions. And so that's why I'm trying to really, as best as we can, drill down on the numbers. And I know the models aren't exact, and I know that everybody's trying to do their best, but the better the numbers we get, I think the better our decision making would be.
Yeah, that's a great point. And I want to just add one other factor there that shows how dynamic this equation is, and it goes to the health of our healthcare workers. Going back to the Blaine County experience, we experienced over a couple-day period a decimation of our staff to the point that it shut down our facility, and I think that's probably one of our greatest concerns right now, in addition to just physical capacity and all the other elements that we need to think about. And as Dr. Souza mentioned, there are some things that we can and should be doing in our community that would mitigate that risk.
Betty Ann, this is Ted Epperly. I'd like to ask a question, please.
Yes, Ted, go ahead.
Again, thanks to both of you gentlemen for joining us and sharing insights and knowledge. Thank you. Dr. Souza, this question is to you. Knowing that we have seen at both hospitals a dramatic increase in hospitalizations and ICU patients and ventilated patients, and knowing that we've seen in the testing community a 4-fold increase in those 40 to 50 and a 5-fold increase in those age 60 and over. Jim, would you, to the best of your evidence-based knowledge, because you spoke to Blaine County and what they've experienced, can you project forward? Because we know that hospitalizations, ICU beds, ventilators are lagging indicators. They're 2 to 3 weeks down the road of true surge from what we're seeing in the testing community right now. Will this become Blaine County in Ada County?
Yeah, thanks for the question, Dr. Epperly. The answer is wholly dependent upon that factor that I called alpha. And honestly, accurately measuring alpha outside that unique experiment that we had, where we had a very contained population within a contained geography that had all of their healthcare needs met within a single delivery system, accurately measuring that is going to be tough. I'm very concerned with some of what I've been seeing, and I know that any efforts to lower that alpha by doing those things that are in line now with the accumulating evidence about avoiding indoor mixing, which was a huge part of alpha, I think, in Blaine County. The other thing, right, that you add into that equation in Blaine County is the cold weather and everybody congregating indoors. Maintaining, spaces, and then this accumulating evidence about aerosols and the spread of this, and wearing masks. I think all of those things, any actions taken to positively influence those things and therefore lower alpha, would mean that the end of our story in Ada and Canyon County does not have to look like Blaine County. But if we were to allow a Blaine County type of alpha, the point of commenting about the treatment and the immunology is that, yeah, the virus really hasn't changed, right? So unless we change something about alpha, we can expect exactly the same outcome. So those are the things we need to work on.
Thank you.
Madam Chair.
Yes, go ahead.
Thank you. This is Diana Laciando. So for Jim and Chris, I'm really thinking a lot about this intersection between Valley and Ada County, given that they're both in our health district, but on any given weekend during these months, we have, upwards of 20,000 residents who are headed up to Valley County. So while their attributed cases to Valley County are still somewhat low, we have so many Ada County residents going there. And I'm wondering if you can speak to your hospital capacity in McCall and what that looks like, and then what does it look like as that starts to be overwhelmed?
You want me to go, Chris?
Yeah, why don't you take this?
Yeah, so McCall, Commissioner Laciando, it's a critical access hospital, and our internal decision there has been that because of the propensity for these patients to worsen pretty quickly, need higher levels of respiratory care support, potentially need critical care support, our internal decision has been that any suspected COVID patients admitted there would be transferred down here to Boise or to Meridian. So that's speaking to the hospital capacity. Your point, though, about the intermixing of those populations is a valid point. Sorry for the background noise there. We recognize that within our own employee population, but in other large employers in both communities. I'm aware that during a surge like happened over 4th of July, at least one of the grocers has employees coming from Boise going up to support the facility there, and then coming back down. So there is a lot of intermingling, and if you're asking whether we might logically contemplate similar strategies in those two counties because of that intermingling, I think there's logic in that.
I guess the sort of larger question, and obviously we can't speak to Canyon County here, even though it's right next door, is that what happens in Valley County, what happens in Boise County, what happens in Elmore County, when and if those communities can't handle patients, they're coming here, and I think that's something we have to continue to be mindful of.
No, that's right. St. Alphonsus and St. Luke's will, because these folks can be quite ill. St. Alphonsus and St. Luke's will, our systems will receive those from a very large geography that frankly extends beyond the borders of the state even.
Madam Chair, Ryan Sturm.
Yes, Ryan, go ahead.
I would also like to add that, very specific to Boise County, we have no medical care facility here, period. It doesn't exist. So any individual or group of people that would become stricken up here with COVID-19 or any other illness is oftentimes life flighted or air medded to one of the major hospital groups immediately straight to the Valley. And so 100% of any spread up here that was causing major issues would immediately be 100% attributed, or 100% count towards Ada County's medical system, because we have zero medical system up here to provide care for anyone at any level for any length of time more than, standard emergency medical procedures of 15 to 20 minutes. And so that's something that a lot of folks tend to forget, and why I kind of brought it up before, if they were seeing patients from other communities, because there are communities that have hospitals but just can't provide that level of support for that many or that long. And we are actually in a unique position here in Boise County because we have zero hospitals and zero ability to provide for those patients in any capacity whatsoever. And so that immediately taxes any patients we have of any kind that are considered serious, is going to immediately impact Ada County's numbers.
Madam Chair, this is Ted Epperly. If I could ask another question.
Certainly, Ted. Go ahead.
Thank you. We know from the data, at least accumulated so far, that when we take a look at children, that 90% or so of infections are from adults to children. About 8% from the data that I have seen are from children to adults. With what you know, both of you, Odette at St. Al's, Chris, Jim at St. Luke's, do you have thoughts around school opening? Do you have thoughts in regards to when you talk about the alpha, Jim, in controlling the alpha, what variable does school reopening bring into this?
Jim, you want to start?
Yeah, I'm happy to. I thought I was on mute. I was trying to come off mute. A great question, Dr. Epperly. I've seen that same data. It's really interesting. My own spouse is a school teacher, just retired, and sort of thanking her lucky stars because she's tried to think about the logistics of lowering alpha inside of a busy school and a busy classroom. Honestly, while I feel the risk is certainly lower there based on the current data we have when compared with, for example, crowded bars filled with young adults. I still think there's a significant risk, and you and I both know that with other viral infections where children, because they interact with their older parents and their grandparents, can become a vector. I mean, I wish I had a good answer for that, Ted. I'm less concerned about that than bars, but I still think that our school systems also need to be getting ahead of it right now around these policies about wearing a mask and creating physical spaces and opening windows, and it's about proximity and the air that we share. I don't know if Chris or Odette have other thoughts.
This is Odette. I don't have anything. I'm sorry, Chris. I don't have anything to add. I think it's a very difficult question, and I do think, however, schools do have to open in some manner with a lot of precaution and mitigation of potential exposure.
Yeah, and I would only add, I think, Ted, if you'd asked that question 6 weeks ago, we would have been, we were certainly at a different place. I think we could see, based on what we were seeing or not seeing in the community, a way that schools could safely open and others. So it's a very dynamic environment, and I agree with everything Dr. Souza said, and it's a tough one.
Madam Chair, just a quick follow on, if I can.
Yes, go ahead, Ted.
Yeah, thank you, Betty Ann. Jim, it would sound like, again, back to your main strategy around protection and mitigation, not so much testing, but protection, mitigation, and with, again, the air we share. I would think that anything that we could start to do as a public health department now in regards to helping control this too would probably be applied to children, so that if we were to develop a mandatory masking for residents of Ada County, that it clearly would apply to all school children. Would that be something that would be consistent with your thinking in regards to the knowledge and data that you've gained?
Madam Chairman?
Yes,
Madam Chairman, just a quick point. We're kind of getting far afield here with our guesses and estimations. And when we start determining what we're going to do with schools, I think that the state board actually has a great deal to do with that, and they have done a lot of inquiries on that. And so I would just suggest caution in trying to make determinants that direction.
Thank you. Dr. Eppley, were you through?
Yeah, just was waiting for a response.
Am I okay to respond?
Yes, Dr. Souza, go ahead.
Yeah, that would be consistent, Dr. Epperly, absolutely. I don't know why we would exempt school kids from that.
Thank you, Jim.
Any further questions or discussion for our hospital representatives?
I just really want to thank you all for being on. I appreciate you making time, and I know this was a somewhat last minute addition to the agenda, but I'd like to see us, at least in some part, continue this conversation, because as we're going to be responsible for mitigation strategies on a go-forward basis, having your insights directly is incredibly helpful. So I really appreciate you taking some time to join us today.
Thank you.
This is Odette. Thank you very much. Thank you for the work that you all do. Bye-bye.
Thank you.
Agree. Bye.
Nettleton, I once again express my appreciation for the hospital representatives joining us today, and we look forward to ongoing dialogue with you. Thank you. Okay, moving forward with the next agenda item is we need a motion to approve the minutes of the June 26, 2020 emergency board meeting. I would entertain that motion from one of the board members.
Betty Ann, this is Ted Epperly. I would move that motion to approve those minutes.
Thank you,
Diane,
Ted.
this is Diana. I'll second.
Thank you, Diana. Any further discussion? If not, I will call for a roll call vote, starting with Boise County.
Commissioner Sturm, aye.
Ada County.
Ted Epperly, aye.
Jane Young, aye.
Commissioner Lachiondo, aye.
Elmore County.
I don't know that it's appropriate. I don't know that it's appropriate for me to vote on minutes for a meeting I didn't attend and wasn't able to.
Okay, thank you. So we do have a majority. The motion does, the approval for the motion does pass. And moving forward to our next item, Idaho Statute 7-206 is communication with legal counsel for the public agency to discuss the legal ramifications of legal options for pending litigation or controversies not yet being litigated but imminently likely to be litigated. So at this time, I will ask for a motion to go into executive session.
Madam Chair, this is Diana.
Yes,
I
go
move
ahead,
we
Diana.
go- I move we go into executive session under Idaho Code 74-206, paren F, to communicate with legal counsel, and that the vote to do so shall be by roll call and recorded in the minutes.
Yes, thank you. Is there a second?
Again, this is Ted Epperly. I will second that motion.
Okay, thank you, Ted.
Actually, this is Kane. Before we get any further, can I ask the person that made the motion to clarify that it's not just communicating with legal counsel, but rather to discuss the legal ramifications of and legal options for pending litigation or controversies not yet being litigated, but imminently likely to be litigated.
Okay. Do I need permission to restate the motion?
Yes, go ahead.
Okay, Madam Chair, then I will again I will amend my motion to note that I'd like us to move into executive session under Idaho Code 74-206 F, to communicate with legal counsel regarding pending litigation or imminent or items not yet being litigated but imminently likely to be litigated, and that the vote to do so shall be by roll call and recorded in the minutes.
Thank you.
And Betty, this is Ted Epperly. I'd second that amended motion.
Okay, thank you, Ted. Okay, we will take a roll call vote on the motion, starting with Boise County.
Commissioner Sturm, aye.
Ada County.
Ted Epperly, aye.
Jane Young, aye.
Diana Laciando, aye.
Elmore County.
Megan Blanksma, aye.
Okay, thank you. Okay, at this point, we will be going into executive session.
Can I suggest that the public be invited back into the meeting if that hasn't already happened?
They are back in.
They're back in? Okay.
Betty Ann, this is Ted Epperly.
Yes, Ted.
I would like to make a motion that the board declare the order entered by the board on June 26th regarding quarantine and restriction be declared void, as the open meeting law was not fully complied with.
Thank you, Ted. Do I hear a second?
Second, Jane Young.
Thank you. Any further discussion? If not, I will call for a roll call vote, starting with Boise County.
Commissioner Reinstrom, aye.
Ada County.
Ted Epperly, aye.
Jane Young, aye.
Diana Lachiondo, aye.
Elmore County. Elmore County.
Aye. Aye.
Thank you. Okay, motion passes. Proceeding on to the discussion and vote regarding potential actions to protect the lives, healthy, and safety within the district as to the COVID-19 pandemic, to include potential amendments to current public health orders for Ada County and consideration of orders for other counties or communities. This discussion is open.
Madam Chair,
Yes, Diana.
this is Diana. I'd really like to ask Russ to weigh in at this point. Sorry, I don't know what's so echoey. We've had a lot of different information flying at us from all kinds of places, urgent care settings, health systems. We're looking at data related to contact tracing, et cetera. And given that, Russ and Kim and team obviously wake up and think about this every day, I really like to hear where his head is at as of 5:36 on a Tuesday. Where are we at, Russ?
Madam Chair?
Yes, Russ, go ahead.
Okay, so where I feel like we're at is we could see the cases rising in terms of case counts back around the 20th of June, actually the week prior to that. And this board requested we have an emergency meeting, which we did, and discussed what was happening, what we were seeing. And that's one of the key indicators as far as the testing that's being done. We heard about that earlier, but the actual case counts definitely were continuing to rise. We were seeing specific areas of concern, which were the bars and the nightclubs. The board chose to go back to stage 3 of the governor's reopening plan as a model. We definitely modified those orders specifically to include bars as needing to be closed. So since that time, fast forward about 2 weeks, our cases continued to climb. Now that would be expected. As everyone has heard multiple times, when you issue orders, there's a lag time from individuals who had been exposed previously at certain environments like we talked about, and the 2 to 14 day lag time from exposure to onset of symptoms, with it commonly being around 4, 5, or 6 days. So I look at our case counts in Ada County in particular. Elmore County, definitely the cases have gone up, as they have for Valley County, and even Boise County has had their first cases reported. Not of concern at this point from my perspective. I completely understand those individuals will likely be transferred to Boise, so it can't be excluded from from the conversation, but right now the cases remain relatively low in those counties. Not the case in Ada County, no surprise, with 500,000 people. Over the course of the last 2 weeks, tomorrow will be exactly 2 weeks since the orders went into effect. We reached a high point last week on July 1st and July 2nd of 231 and 235 cases respectively. Since then, the cases have gone down, but not substantially, with 181 reported on July 3rd. July 4th was 160. And then on July 5th, we have about 75 cases. But excuse me, I'll tell you, on a Sunday, I'm not sure what it is. If it's lab reporting slows down that day, we did have 75 cases. And it looks like for yesterday, will be around 125 cases. So if you look at the trend just since July 1st, it's definitely heading down. That can change fairly quickly. I know there's some bottlenecks occurring again with testing, as Dr. Souza had specifically mentioned. But at this point, what I feel like needs to be done based on our experience after 2 weeks, we should start seeing the impact of the very highest risk environments that are now closed. Certainly long-term care facilities, that's another area of concern because of the severe consequences to individuals who are residents of those living environments. So we closed those to visitors as a means to protect them from infection. I feel like we're starting to see some of that benefit. The one area I would recommend is that in the orders, we have, again, modeled after the governor's reopening plan, gatherings of more than 50 people, which tend to be focused on social gatherings, not a business environment. And it says should be avoided. I would recommend that the board consider changing that from should to shall. And it's more a matter of interpretation. These are orders, not recommendations. So that's recommendation number one. I would definitely not move forward with the current orders as is with that one addition. In terms of face coverings, I think that Dr. Souza explained that extremely well. Certainly what happened in Blaine County was at a different place in time. I think from where we are today, there's a much heightened awareness as far as what we need to do, physically distance, and wear face coverings, stay home if we're sick, but that's not routinely practiced. So I would recommend, beyond what I just suggested with the current orders, is that this board give me and the staff here at Central District Health the opportunity to draft orders for face covering requirements for at least Ada County and possibly Valley County, given what you just talked about, Commissioner Lasciando, with the frequent travel, especially on weekends, to Valley County from Ada County, and present that at our next meeting, which is scheduled for Tuesday, July 14th, for a consideration to add that to the orders should you choose to move forward with my recommendation today. If by chance things change between now and 1 week from now in a very dramatic and negative direction, then I would recommend we call a special meeting and do the public notice 24 hours in advance and further discuss the face covering orders. The last comment I'll make about that is I think when I think about restrictions, wearing face coverings might not exactly be comfortable, but it's not going back to stage 2 or stage 1 or stay home orders. And my real concern is if our case count goes the other direction, as far as, like I said, we're starting to see a somewhat of a decline, and we don't get on that fairly quickly, our hospitals will undoubtedly be overwhelmed, as we heard today, and not be able to provide the appropriate level of care for COVID and non-COVID patients. So I'll stop there.
Thank you, Russ. We appreciate it. And all the time you spent on the phone with me in the last couple weeks.
Chairman Nettleton, Ted Epperly with a point of clarification.
Yes, Ted, go ahead.
And maybe this can be best addressed by Mike Kane. When we came out of executive session and our first action was to void the prior order of June 26th, do we need to provide an updated order that covers the period of time that we've had? In other words, a restatement of the existing order now that we've gone through a curing process, or is what we're considering now the replacement order? I just need to be clear on that, because as I understand things as a physician, not a lawyer, we've now voided our order. If we assign a drafting of a potential order to Russ to come back to us with, do we have a circumstance where we have no covered action?
Madam Chairman, Dr. Epperly. Yes, thank you. If you just assign Russ to work towards something, there is no order. And so essentially what happens is Ada County goes back to stage 4, bars reopen. So if the will of the board is to not have that happen, then you're going to have to restate a new motion and a new order. That can be identical to the one that you've already had, or it can amend it. It's entirely up to you as to how that gets amended. As far as instructing Russ Duke to work on a potential order towards masks, that can be included, but you would need to have something essentially restating your last order in order to keep things in place as they currently are.
Thank you, Mike. Madam Chair, if I can clarify then now with Mr. Duke.
Yes, go ahead.
So Russ, just so that, again, we do this correctly for the good of the public here, we can restate the order that we now are covered with. Are you suggesting that we do that and work on a further set of orders, or are you suggesting that we modify the old order to become the new order today?
Madam Chair.
Yes, Russ, go ahead.
My recommendation is that the order that was just voided be re-implemented with one change, to change gatherings of more than 50 people, both public and private, shall be avoided rather than should be avoided. That is the only change I recommend to the current orders, but as Mike Kane said, they would need to be re-implemented effective immediately, with the second part of that being to draft orders for the board's consideration no later than next Tuesday on the 14th. So it would be these same orders with the addition of language around face covering. So these orders need to be implemented today, in my opinion, with the one change of should to shall. And then I would work on orders, a draft set of orders for consideration of the board no later than the 14th. And that would be a modification of the orders you would approve today, should you do so.
Madam Chairwoman?
Yes, Megan, go ahead.
Sorry, question for Russ. So because I was not aware of the last meeting where the order was implemented, can you tell me what mechanism was used to implement the order? Like you say cases, but when we say cases, that means lots of things. So can you tell me what numbers, what metrics were used to implement the last order?
Sure, Madam Chair.
Yes, go ahead, Russ.
The primary indicator that we used was the rapid rise in cases being reported to us. And not only the rapid rise in cases being reported to us, but there was additional information as far as the positivity rate that our health systems talked about earlier. And the president and CEO of the Primary Health Medical Group, who does a large percent of testing, I don't know exactly what it is as far as for Ada County, was also sharing his data. So it was not just the number of cases, which were concerning when we were about 4 to 5 cases a day throughout much of May and into early June. We then saw a significant uptick in cases as well as positivity rate. And that was the primary reason the original orders were issued.
So, Madam Chair, this is Ted Epperly.
Go ahead.
I'm prepared to make a motion at this point that will, if you will, cure the voided motion that will incorporate the recommended language and allow then for further consideration for a draft set, if you will, of following actions for the upcoming meeting on or about 14 July.
And if that's a motion, I will second that.
Madam Chairwoman, point of clarification.
Yes, Megan, go ahead.
Is there, if Mike Kane's still on the line, is there anything preventing the director of the health district from drafting any type of order?
Madam Chairman, no. No, there's nothing preventing him from doing that. He can draft anything.
So my understanding is he doesn't need board permission to draft.
Madam Chairman, that's correct.
Okay, thank you. The motion has been made and seconded, so I will call for a roll call.
Actually, Madam Chairman, this is Kane. I need clarification myself.
Okay.
What I thought I heard, and we need to make this clear, was the motion was to essentially adopt the last order as currently written without making the recommended change from Mr. Duke, changing the word should to must.
Shall.
Is that right? No.
What I was going to do, Betty Ann, if I can comment back to Mike, just because I agree with him, we want to make sure we get it right. Third time's a charm, right? Mike, what I was thinking about doing is taking our former motion, and I will state that verbatim so that we're consistent with what we've done. And I will add into that the recommendation that we, for gatherings that are, that we have gatherings that are less than 50, and I will use the word shall. That's what I was going to do.
Then I'm going to suggest that you withdraw the previous motion that was seconded, because I didn't hear that in there, and you need to restate your motion.
Well, it wasn't, Mike, it wasn't a motion. It was, I was prepared, I was prepared to make a motion, and I think Diane jumped on and said, if that's the motion, I am approving the right to make the motion is what I took away from it. If not, then I would agree. We just, let's null and void that, and then I'll make the motion.
Yes, start again.
Okay. Then Betty Ann, I will withdraw. Yeah, I will withdraw the prior attempt at a motion at this point.
Okay, and would you please restate your new motion?
And do we just for clarity, Diane, do you need to second that and then we vote to withdraw?
Just withdraw the second.
I withdraw the second.
Thank you, Diana.
Thank you. And Betty Ann, if you're now ready, I'll give this a go.
I am.
Okay. I move the following to be made into a legally worded order. That I recommend that Ada County move back into stage 3 for the control of COVID-19 outbreak of significance immediately to include bars and nightclubs. The restriction would apply to employers, business, and individuals in Ada County, Idaho. That we use syndromic, epidemiologic, and clinic numbers to determine when these restrictions can be lifted. And that gatherings of individuals shall be limited to less than 50, and that Central District Health will develop a messaging campaign that includes multiple healthcare leaders to help amplify this message across all of Ada County, and that Mr. Russ Duke will develop a draft set of orders to represent to the board on or about 14 July for further consideration for further action.
Second, this is Diana.
Okay, any further discussion on the motion?
Madam Chair, I had a question. It was brought out to our attention, I think, that we were doing a modified stage 3, or are we doing in exactly the stage 3 that he had defined?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
The
Go ahead, Russ.
order, thank you, Madam Chair. The order that we created that had been in effect was a slight modification to stage 3, as pointed out by Dr. Epperly, to include bars and nightclubs. There was one other component of that that was simply a recommendation for individuals traveling out of state to areas of higher incidence of COVID-19 than are occurring here in our communities. And that, quite honestly, is nearly impossible to try to determine as things are rapidly changing in different communities across the country. Again, it was a recommendation. So that was the one thing that I can remember in particular that we excluded and included bars and nightclubs.
Madam Chair, this is Ted Epperly again.
Yes, Ted, go ahead.
Yes, Jane, to your question, in the original motions that were made, we didn't use the language modified stage 3. It was just the inclusion of bars and nightclubs, which made it the modification.
Okay.
And then I think when Russ and Mike Kane drafted the order set up, that was the formation of that drafted set of orders. So I specifically worded this exactly the way that we've worded in the past so that we don't change intent, and just inserted the modifications that we discussed so that we try to stay as pure and consistent with this as possible. And so I just wanted to explain that, Jane, that's where the modification is in the language of bars and nightclubs.
Thank you.
Okay, any further discussion on the motion? Okay, the motion has been seconded. No further discussion. I will call for a roll call vote, starting with Boise County.
Boise County Commissioner Sturm, aye.
Ada County,
Ted Epperly, aye.
Jane Young, aye.
Commissioner Lachiondo, aye.
Elmore County.
Megan Blanksma, no.
Okay, thank you. All right, the motion does pass, and this brings us to almost the end of our agenda today. Were any further comments you had to add before I ask for a motion to adjourn?
Betty Ann, this is Ted Epperly again. If I can just add one additional thought for the good of the group. Russ, as you contemplate drafting these based on the data we've heard today, I just want to reiterate a couple points that I think are really important. And that is that there's going to be about a 2 to 3 week lag between different phases of this hitting the public, so that as we identified the high water marks that Russ was talking about with 231 and 235 cases in Ada County, it'll take 2 to 3 weeks for that to translate into full hospitalizations. About 2 to 3 weeks additionally for that to translate into intensive care unit and ventilator cases, and about 2 to 3 weeks after that for death to occur. That's the way this works. And I just wanted to call out that in Florida, in Texas, in Arizona, what those communities and states were dealing with 2 to 3 months ago is exactly what we're dealing with now. And so if we do not take aggressive action towards this, and I think we heard this from both of our hospital experts, this will develop into a full-blown situation where we have sickness and death. And I just want to make one last point, and I'll stop. And that is that I absolutely believe we do need to go to mandatory masking in Ada County. It's back to the point of we can control only what we can control and what individuals can control. And what each of the individuals can control is their social distancing, their hand washing, their mask wearing. And if we do that, then I think we will absolutely start to protect human life, which is the charge of the health department. But also, as an added benefit, we'll start to protect the economy, businesses, employers, jobs, all of it's tied together. So I think it's really an important point to go to the masking as a universal mandate, at least in what we can control, and that's Ada County. I recognize that Valley County, Diana, you've made a great point on that. That's something Russ will take into consideration as he drafts. I'm not sure it has to apply to Boise County or Elmore. That's something Russ will consider. But I think for Ada County, it's a must, and I'll stop. Thank you.
Madam Chair, this is Diana. Ted,
Yes.
thank you so much.
Yes, Diana, go ahead.
Thanks for all your guidance that you've provided and this learning curve as we've been bumping along. One of the things that I had to come to grips with really early through all of this is that if we do our jobs right, it will look like an overreaction. And that's just the nature of it. We keep hearing folks saying, but we haven't run out of beds yet. The ICUs aren't full yet. Well, that's the lagging indicator. And so I think this is the hard thing, and we're trying to bring the community along with us. And I'm actually really very excited by it. Looks like we had a lot of people tuning in to watch our meeting today and hopefully hear from the hospital leaders, because I think so much of this is trying to help educate the public as we too are being educated throughout this process. So appreciate you and your leadership and certainly the staff at CDH as we've been grappling with this.
Thank you. I think that echoes all of our appreciation from every member of the board. Any further comments? Hearing none, I will ask for a motion to adjourn.
Betty Ann, this is Ted Epperly. Hearing nobody make that motion, I will make a motion that we adjourn.
Thank you, Ted. Is there a second to the motion?
This is Diana. I'll second.
Okay, thank you. No further discussion. I will go ahead and call for a roll call vote for adjournment, starting with Boise County.
Commissioner Surmai.
Ada County.
Ted Epperly, aye.
Jane Young, aye.
Commissioner Lachiondo, aye.
Elmore County.
Aye.
Thank you. Okay, motion passed. We thank everybody once again for their participation and their patience in moving forward with this challenging issue. So thank you so much, and the meeting stands adjourned at this point. Good night.
Good night. Thank you, everyone.
Thank you.
Be well.